Good evening and a very warm welcome to tonight's webinar hosted by RCN Students called Let's Talk About Death. This webinar is a part of a series of ongoing webinars on a range of topics applicable to students, ranging from bullying in nursing to professional values and to changing of the standards and clinical supervisions, all of which are uploaded to our YouTube channel, the Royal College of Nursing, after they've gone live. So over the next hour, I'll be talking to two experts in end-of-life care who I'll introduce in a minute, all about death, dying and end-of-life care. Sadly, during COVID-19, we've seen a huge rise in deaths. I myself have seen a lot. I've been working on the front line during the pandemic, and it just felt appropriate to have a webinar on this. So we can feel more comfortable about talking this, as it's often seen as a taboo subject. The format of tonight will start with 6 formal questions, which my two guests have seen already, and then we'll move on to audience submitted questions. I'm joined tonight as well by the lovely Molly, who's my co-host, who I'll let introduce herself.
Thanks, George. So my name is Molly and I am a final year student at Montfort University. I'm doing mental health nursing and I am also vice chair of the RCN Students Committee. I'm going to be behind the scenes tonight, filtering through questions which you guys watching at home have submitted, making sure that we can get them answered.
Lovely, thank you very much. And I forgot to introduce myself as well, sorry. My name is George Cade. I'm a 3rd year adult field nursing student and I'm the RCN Students Committee member for Wales. So I'd now like to introduce my two special guests. My first one is Maria Parry, who's a former clinical nurse specialist in palliative care, and she's the current lead for palliative care at the University of South Wales. Maria.
Hi George, hi everybody. My name is Maria Parry, and as George has rightly said, I'm palliative care lead at the University of South Wales and also the Bachelor of Nursing course leader at the university. I trained as a nurse in the mid-80s and on qualifying I worked on a surgical ward where I met a young lady who had quite advanced bowel cancer. She'd undergone surgery and was waiting for some chemotherapy. I realised one evening after sitting with her that she wanted to talk. She wanted to talk about her family, her fears, her thoughts about her chemotherapy, which were not clear in her mind. And I realised at that point in time that my nursing career wasn't going to be spent on a surgical ward. There was much more out there that really was greater than surgery. I was lucky enough after that to, palliative care was in its real infancy at that point. It had become a medical speciality, and I was lucky enough in my career to work as a sister for Marie Curie Hospice. I've worked as a clinical nurse specialist both in hospital and community, and the last 20 years I've been pretty much working in the university, developing postgrad palliative care education and undergrad palliative care education, which is incredibly important, sharing my knowledge and skills with the nurses of the future. And I've been really privileged to work with amazing students, patients.
Lovely, thank you very much, Maria. And I'd also like to introduce Dr Kathryn Mannix, who's a palliative care physician, and she's author of a wonderful book called With the End in Mind. Kathryn. I think you might be on mute, Kathryn.
Hello, I'll try that again with my button unmuted. Hello everybody, and thanks so much for joining us. I trained in medicine at Newcastle Medical School in the late 1970s, qualified in the early 1980s. And halfway through my training, we were put onto wards to meet real patients, and I suddenly discovered, to my horror, that doctors didn't have the relationship with patients that I wanted. Nurses did. And I spent many evenings weeping down the phone to my parents to say I need to leave medical school, I need to train a different way. And I think I was very lucky that I was rescued by the nurses on the wards where I was working and shown how to be the kind of doctor that they wanted doctors to be. And palliative care was just opening up as I was finding my interest in cancer medicine wasn't sustaining me in that relationship with people that I was looking for. So I've had a very, very happy career working in a specialty that was growing at the same time that Maria and I were pioneering it, really. And one of the hallmarks of it is that blurring of professional boundaries, where very much nurses and doctors are working together, and there's cross-working, and interprofessional rivalry is very, very unusual, and interprofessional cooperation is the rule. So I'm delighted to be here with you all talking about palliative care and the huge difference that excellent nursing makes to that.
Lovely. Thank you both very much, and thank you so much for taking the time on this Friday evening to join us as well. So we're going to start off with our very first question, which I'll ask Maria to answer first, and then we'll go to Katherine. So something I know you're both passionate about is making death less of a taboo subject. Why do you think it's important we talk about death, both not just in our clinical settings at work, but also in our own lives? Maria.
Thank you, George. I suppose for me, there's an element here that we need to normalise death conversations, and if we can't hold a conversation in our own lives, then how can we eventually make it normal in the medical and the nursing world that we live in? We are, in health, we are products of society in general. And as Katherine nicely said there, we work interprofessionally, so being able to share those views and thoughts, they ultimately come from our own perspectives. So I think using terminology in our own lives, such as dead, dying, will eventually help to change the terminology that we use in a clinical setting, and that will help ultimately to change culture. So discussing what we want, from funerals to music, and things like dying matters that we have across the UK, things like death cafes, things like this, all help in our own lives, which will ultimately help in a clinical setting. It's really normal in my family. For my children, they're very comfortable in talking about death, they're very comfortable in talking about dying, they're very comfortable in talking about what will happen one day. And they are happy to share those views and thoughts. And I think that's the biggest thing in our own lives. It's important because we can't change anything else unless we do it ourselves. Hope that makes sense there, George.
And I'd absolutely agree with that. That's one of the things that was a game changer for me. Probably 4 or 5 years after I qualified, having worked in hospital medicine, done lots of exams, worked towards a career in oncology, so in wards where lots of people were dying in those days, because the success rates for curing cancer were very much lower in the early 1980s. So I'd seen a lot of deaths before I went to work in a hospice. And then I heard the medical director of the hospice that I'd gone to work in describing the process of dying to one of our patients. He took me with him, and I was astonished. I'd seen hundreds of people die, and I hadn't realised that there is a process, just like giving birth is a process. And even though the individual parts of it will vary a little bit from person to person, and it's individualised by who they are giving birth, the same way in dying. And as he was describing it to her, part of my brain was thinking, you can't possibly describe dying to a person who's dying, which was me living that societal taboo. And the other half of my brain's thinking, oh yeah, that is what happens. Yes, I have seen this, but I've never stepped back and seen the process, because as clinicians, we're so busy worrying about that person's blood pressure and that person's renal function and that person's oxygen saturations, that we don't stand back and see the overarching process. And because it hasn't been discussed at home, because it isn't known about in society, we bring people like us into schools of nursing, schools of medicine. We teach them to stop people from dying, but we don't actually discuss when somebody's got permission to die, when dying is the thing that now is happening. How do we support them and enable that to be the way they would want it to be? So I think we've changed the way we do midwifery in this country by women understanding what good antenatal care and good birth care is like, and now that's what they demand. And we need people to understand what good end-of-life planning, good end-of-life support, good end-of-life care looks like, and then they can demand that. And actually, it's not very much about us as professionals. If we're around at all, we need to be in the background, managing symptoms a little bit, reassuring if people are being distressed. But actually, this is a societal event, it's a personal event, and our job is to get it to run smoothly while we're as out of the way as we can possibly be.
Thank you very much. And our next question is for Kathryn. So something I've seen a lot of when working in COVID is withdrawal of treatment. So I just wanted to ask you, what kind of circumstances is it you'd withdraw treatment from a patient, and what would we then do for the patient?
If you can unmute, please, Kathryn.
Sorry.
I'm being very dim this evening. I think it's a really great question, and I'm going to broaden it from COVID to just think about one of the things I think we really need to get better at as healthcare professionals is recognizing when people are so sick that they could die, and yet also we've got the potential still medically possibly to stop them from dying. So there's a kind of parallel care going on where we're starting some treatment in good faith in the hope that it might save that person's life, but we also recognize that it might not. And because we're not great at talking about dying, we're not great about talking about anticipating dying either. So families very often don't understand that this trial of antibiotics is to see whether we can improve this pneumonia enough to save this person's life. This trial of using a ventilator is to see if we can support their body while their other organs that are failing are retrieved and get back on an even keel again. And so we then end up in a situation where the treatment we hoped would save the life hasn't, and it's not helpful to the person, it's not helpful to keep it going, but we've now got to negotiate stopping it. Where if we talked at the very beginning about saying to people, look, I can't promise you this will work. Your dad is so sick that he might die. This is what we're going to try if you think he will accept it, or if he's well enough to negotiate it, of course, we'll ask him. But we can't make you any promises here. And then that daily update. Now, during COVID, suddenly we've had to do that, but like daily, for lots of people, and suddenly people are starting to get it because it's in the newspapers as well. So we're going to try oxygen and we can't promise it will make a difference. We're going to start CPAP and we can't promise it's going to make a difference. We could take this person to the intensive care unit, but their body is already so battered physiologically that we're not sure that they would survive on a ventilator. And now there's a really critical decision to make. So a withdrawal of treatment almost always is not a surprise to the clinicians involved, but it's often a surprise to families because we haven't dared to talk about the possibility of dying in anticipation of that. So once we are withdrawing treatment, the really important thing is that we're not withdrawing care. And there's a wonderful paper on managing end-of-life care by the Intensive Care Society that talks all the way through about we may be changing treatment, but we are never reducing care. And actually what we're doing is intensive caring, just not with those machines. This is all about making the difference now to the person and the family that's important to them. And that's all about dialogue, and that's all about bedside nursing and really, really listening to what our patients and their families are saying to us.
Thank you so much, Kathryn. My next question is for Maria, sort of just following on from that. So as nurses, what's important when we're caring for the dying patient? Is there anything that we need to look out for?
Thank you, George. Yeah, I think one of the most difficult aspects for a nurse or for anybody in medicine, in healthcare, is diagnosing dying, for want of a better word. It does make me smile and it does make me chuckle when you still listen to people who on occasions think this is easy. Then people seem to think, oh, you know, caring for people who are at end of life and making some of those decisions, it's some of the hardest decisions that people make when people are trying to look at the signs and symptoms that we see and predict that somebody has entered that phase. I think it's really complex for nurses who are an awful lot of the time in the acute sector. We are trained to want to cure. We are trained to almost have this, we need to keep people alive. And when somebody says, well, actually, we can't and shouldn't do anymore because, as Kathryn's just really nicely said in the previous question, somebody is extremely sick, somebody is very unwell and they are sick enough to die. And that's got to be the best sentence I think I've heard in absolute years, because it is putting things in reality. Somebody is so sick that they can die. And I think what we are looking for is people who meet that criteria. Now, again, that's not easy. Everybody's experience is different. Different illnesses have different signs and symptoms. Different illnesses will have a different trajectory. And again, when I see people who sort of smile and sort of suggest this is easy, you almost want to say to somebody, you've got all these different illnesses with all these different signs and symptoms, and we are asking you to decide one day, and not nurses on their own or doctors on their own. This is a multidisciplinary decision. Actually, that person is dying. That person is not going to get better, not be able to get well. So it's a really hard decision based on lots of different signs and symptoms. The gold standards framework offers the prognostic, I can never say it, indicator tool. We need to look at the diagnosis of that person and put it in perspective with the signs and symptoms that we see. I think what we look for, I think we should be able to plan ahead and signpost as much as we can. People need time. I do appreciate and understand, and certainly during COVID, we have not had that time that we would have liked. But communication is essential. We need to communicate with patients and families and to be able to look for those signs and symptoms that we see. Things like, what do we look for? I think one of the biggest things that I want to say to people is a little bit earlier on than the active dying bit that a lot of people will see. What do we see before? What do we look for before? And I think we can see things such as behaviour changes. They can be incredibly subtle, but we can see behaviour changes. We can see maybe somebody is sleeping a lot more than they would. Maybe somebody's appetite is a little less than it was. These might be very subtle things to begin with that will develop and progress. So when caring for that patient, then I think they are the things that we should be looking for to guide us to that point.
Thank you very much, Maria. Next question is for Kathryn, and I know you've explained this beautifully before, Kathryn, in a video with the BBC. What is it that actually happens when somebody is dying? And as healthcare workers or as relatives, what is it we see happen to them?
Oh, thanks, George. This is kind of picking up where Maria left off there, that the subtle changes gradually move towards less subtle changes. So the early changes are just being more tired, needing more sleep. And it's very good way of helping families and patients themselves to notice what's happening by asking them to report, you know, how's your energy levels these days compared with a month ago or 3 months ago, and help people to see how things are changing. So towards the very end of people's lives, they are increasingly weary, and it doesn't really matter whether we're talking about heart failure or respiratory disease or cancer, these diseases of inanition, if you like, all lead to a very similar process at the very end of life. And if you're dying from something much more sudden than that, sepsis, for example, it's the same process, but at a more accelerated rate. So what we see is very, very profound tiredness, not being interested in food, not being interested in drinking. That's really hard for families because we're a nation who shows people that we love them by feeding them. And when you're discouraging families from feeding because the patient is so exhausted trying to please everybody, it's really important that that's explained in a way that's saying this is about their comfort, this is about respecting their wishes, because families misinterpret it as we're withholding food or we're withholding fluid, which of course we're not doing. Towards the very end of life, people are asleep almost all of the time, and they start dipping in and out of unconsciousness, which they're not aware of. When they wake up, they say they've had a nice sleep, but we will notice it because there'll be a phone call or visitor, or particularly medicine time, and we can't rouse them. And that matters for two reasons. It matters because it's a marker of a change in the process. They're into the next stage of the process, if you like. But it also matters because if they can't wake up to take whatever medications are managing the symptoms of the illness that they're dying from, then in the periods when they do lighten in their unconsciousness, they will be aware of symptoms and they will have discomfort, and that's something we want to avoid. So that's around the stage that we'll start changing medications to a non-oral route. That's usually subcutaneous, but we've got other routes. We've got buccal, transdermal, rectal routes that we can use if we need to. Until in the end, the person is just unconscious all of the time. And most of the professionals and students who are listening to this will have seen this process happen. The person who's deeply unconscious, the only part of the brain that's still working now is the bit that works the breathing. And so instead of our controlled and quiet breathing, they go into reflex breathing cycles, moving between fast and slow, moving between deep and shallow, not relaxing their throat as they breathe out. So they may breathe out through their vocal cords and it will make a sighing noise. It's so important that families understand that that isn't groaning, that isn't trying to speak, that's deep unconsciousness and an unawareness of the throat. Other parts of the cycle, it might be shallow but quite fast and it sounds like panting. So again, really important that we are almost midwifing the dying. We're explaining as it's proceeding what's going on here, that this sort of breathing is a reflex. It means the person's very deeply unconscious. And perhaps the most worrying sound that people make of all is the sound that people sometimes call the death rattle, where there'll be a little bit of fluid at the back of the throat. So it might be saliva, it might be mucus from the lungs, it might be whatever we just cleansed the mouth with and a bit's trickled backwards. And we all know, and it's really helpful to ask families to think about, if you normally have a tiny bit of fluid or a toast crumb or something like that in the back of your throat, you'd cough, you'd swallow, you'd splutter, and they're not doing it. They're simply letting that fluid lie there. So that tells us that they are not feeling that really sensitive part of the back of our throat that's part of our survival reflexes, and it's switched off. Messages about sensation are no longer getting to the brain. And because of that, because they're breathing and it's not obstructed, the air's going in and out of their trachea, but it's bubbling through that little thin film of fluid, and it's making this very peculiar rattling noise. And it's the only time in medicine that we hear this noise is profoundly unconscious people with a little bit of secretory pooling in the back of their throat. Under other circumstances, we'd put somebody as unconscious as this into the recovery position to protect their airway until we could intubate them. But obviously we are doing excellent, kind, non-intervention nursing care in the anticipation of dying. So we're not going to do that, but we are going to explain to the families that this noise doesn't distress the patient. It's actually showing us that they're beyond feeling distress because they're tolerating things touching, tolerating fluid touching the back of their throat. And then as the breathing cycle moves on again, there will be pauses, it gets slower. Sometimes the pauses are very long. Sometimes that takes inexperienced nursing students and medical students by surprise, because we see somebody take what we think is the last breath and there's a really, really, really long pause. And we're just about to say to the family or go and get a more qualified member of staff, and the person suddenly starts their breathing cycle again. So we just need to sit and accompany, or pop in and out and accompany, check how people are doing, narrate it, and there will be an out breath that isn't followed by an in breath. It's as gentle as that. All of us in palliative care have walked into a room, whether it's in a family's home or whether it's in a hospital or hospice, with the whole family gathered around the bed, and the person they're sitting around has recently stopped breathing and nobody's noticed yet. It's that gentle. I can see Maria nodding. And, you know, I always used to wonder what to say at that point, and I just used to look in and say, so how do you think his breathing is? And they'll all look, oh, and then they'll realise. So it's very not like on the telly. It's very not like a soap opera. It's very, very gentle. And it will be like that provided we've had meticulous attention to symptoms management, so people aren't aroused from their unconsciousness into a state of semi-consciousness that's associated with a sensation of breathlessness or pain or whatever not properly managed symptom is going on. So it's really important that we manage symptoms so that dying can be peaceful.
Thank you so much, Kathryn, for your answer. My next question is for Maria. Death is something, as healthcare workers, we can be very uncomfortable talking about to our patients. Sometimes I've seen myself, many times, patients asking a nurse, am I going to die? Only for it to be hushed and dismissed. How is it you think we can go about talking to death to our patients? And in the past, how have you answered that dreaded question of, am I going to die, nurse?
Oh, okay, interesting question there. I will go back to a previous answer to some extent, because I think this also comes from a society perspective, that we change words that we use. We use the right terminology. I have never, ever been a fan of euphemisms. They allow confusion. They allow confusion to develop. People will hear what they want to hear sometimes, and they will hear a word that to them means something, but it certainly doesn't mean dying or going to die. And if you think of some of those words, you know, poorly, what does poorly mean? And then if we start talking about sort of other terminology, you know, in society, let alone in sort of healthcare, what do we mean? So I think, how do we talk to patients? How do we answer that question? Then we need to start using the right terminology. Secondly, I think the right words people can understand. And I think people, the reason that I think sometimes it's hushed and dismissed is it's from a very kind place very often. It's from a place of protection and not wanting to hurt people. And people think by using kind words that it will be helpful. And actually, I think all that happens a lot of the time is it becomes confusing rather than it being helpful. So I think using terminology and being able to have that conversation is important. I think we need to answer that question at any point in time. We need time, and we need people to be ready for that conversation. So what are the patient's expectations here? What do they know? What do they expect? And sometimes if you ask somebody to tell you what they think, they'll actually hear themselves say those words, and for the first time they speak, and they will hear those words themselves. And I also think sometimes patients will know a lot more than we think they know. So I think sometimes asking that question back to patients, checking what they understand, is really important. Compassion, emotion, honesty are all things that go with that. Have I ever answered that question? Yes, many times. Honesty, I think, is incredibly important, and but it comes with this: what does somebody know? What do they want to know? And do you have time to have this conversation? I have seen nurses who are so busy, people are afraid to ask, people are afraid to have a conversation, or they ask a question and people are like, no, that's fine. No, of course you're not, because they haven't got time. Well, that's probably one of the most important questions you will ever be asked in your whole career, as far as I'm concerned. And at that point, you need to allow time to sit and answer it. I think it needs to come with acknowledgement of this is hard to hear for the patient, that we need to be able to offer something other than yes, if that is the answer. It's never going to be easy conversation, and I think we also need to allow time. And as nurses, sometimes we can be very bad because we want to fill every single silence that there is. So I think allowing somebody time to reflect on what you've said, how you've answered that question, is really important. Realistic hope, I think, is important as well, and also that choice and control that comes with that question and the answer. And I'm going to ask Katherine to add to that, because I'm really sure that she has probably answered that question probably more times than I have, and I'm sure she'd have something to add, if you don't mind, Katherine.
I would completely endorse everything you said. Whenever I get asked a difficult question, a question that could go anywhere, I answer it with another question. And I think that one of the things that helps you not tread into territory that you're not welcome to go into is to move forward by asking questions. And you're using Socratic questioning. It's a technique of guided discovery. So, do you think I'm dying? That's a really important question. Validate it. I wonder what makes you ask me that. And then they will tell you, well, I'm worried about this, I'm worried about that. I would never lie. People are prepared to negotiate around this. So I very often would say, if you were so sick that you were dying, how much information would you want to be given? Are you the kind of person who likes to know everything and all the details? Or are you the kind of person who prefers other people to worry about the details? I once had a lovely man who said to me, listen, pet, if it's really bad, don't tell us, tell me wife. And that was really, really clear. So I was able to go and chat to his wife because he wanted not to have to deal with those sorts of conversations. So questions are a really good way of not turning it into a game of cat and mouse, but gently moving it forward at the pace that the person is prepared to go. The other question that you might find a really useful question is, when you're thinking about what might happen in the future, what's your best hope? And what's your worst dread? And then, having thought about those things, we can work with people so that what's going to unfold for them becomes as much like their best hope as it possibly can be, and the least like their worst dread as it possibly can be. And my real plea is that when somebody says, and the thing that I'm really worried about is that I'm going to die, that's never the thing that they're really worried about. There are layers underneath that. So when you think about the idea that you're going to die, what is it about that that troubles you the most? Is a really useful question, because you'll go from there to, what will dying be like? Will I be cast into hell? Who will tell my children the facts of life? Will my husband marry again, the swine? You've got no idea what it is that other people might be worrying about unless you ask. So talking about dying is never the bottom line. There's always stuff underneath that. And it's really helpful for people if we just very, very gently probe that. When you're talking about dying, when you're thinking about dying, what is it about that you find the most difficult to deal with? And what are the things that you feel you're already dealing with quite well? Let's remind people that you can be feeling bad about some stuff and coping with other stuff at the same time, because people are hugely resilient, doing great things.
Thank you so much, both of you, for your answers. The final one of my questions is for both of you. I'll start with Maria first. So working during COVID-19, sadly something I have seen a lot of is families not being able to visit their loved ones when they are dying. How is it you think we can support these family members, and in normal times, how would we support them? I know you've kind of touched on this quite a lot already, so I wondered if you could kind of describe what it is you think we should say to them as well, because I find I'm quite often lost for words at times. So I'll start with Maria, please.
You know, George, I think sometimes being lost for words is very appropriate, because I think we probably had talked around this a little bit, but one of the first things that I think that I need to say in how we can support these family members is you have to look after yourselves, because this is really, really difficult, and the word unprecedented has been used a lot, but they are very unprecedented times, and you know, you do need to look after yourself. You use peer support, use multidisciplinary team support. Caring for anybody that's dying can be emotional, and it can be challenging, and it can take a little bit of you. So I think any kind of care can do that. So I think in order to support somebody else, you need to support yourself. So I think knowing what you need, knowing what you want, knowing how resilient you can be are really important. Knowing what you need to unwind can be really important. That in order for you to be able to give, to help somebody, you need to help yourself. I think you also need to know, and I think this is really important as any student or any healthcare professional, you need to know your level of competency, and you need to know your role. And are you out to your depth? Is there things here that you need to sort of say, I need to learn from somebody else, and I need to help, get somebody needs to help me here, and I think that's okay. Do you know, a lot of the time I have said, do you know what, I'm not sure, but I know somebody who can, and then you learn from what they have said and from what they have done. So I think to support somebody and support family members, sometimes saying nothing is fine. Silence can be good. I think one of the most difficult things for me would be the lack of ability to maybe touch, that kind of touchy-feeliness that has been taken away to some extent by COVID. I would have found particularly difficult. But I think acknowledging those difficulties with family members, I think, is really important. Again, a lot of things have been done by telephone. That's a completely different communication strategy than it is having somebody face to face, because you've totally taken away those sort of non-verbal things that we pick up on, and that is so hard. I think the other thing to bear in mind, depending where you are, you might need to do this through an interpreter or something like that anyway. It may be that we are not communicating and supporting somebody directly anyway. Again, that support for family members, I'll come back to maybe some of the things that I've said already. What do they expect? If you are having that conversation with somebody, are they on their own? Are they prepared? What information? So to support them, they need those things. They need information, but is it the information at the right time? Do they need somebody else with them? What are they expecting to hear? And that can be important. Again, that expressing compassion and showing empathy. I think some of the things that you can to support somebody, people will see your or hear your empathy and your voice, and I think that comes across. And again, I think in normal times, I don't think I tell you much different to some extent. Communication, signposting, and I do think COVID to some extent has changed our perception of death, but also that perception of how we communicate around death and dying. And I think for lots of consultants, palliative care, physicians, nurses, it has changed the way that maybe that we do support families, because an awful lot of it has been done via the telephone, which is really hard.
Yeah, I'd absolutely agree with all of that. And one of the things that we're learning a lot about now is how do you manage the silence that's so important in these conversations, because the silence is when people are processing the information we've given them. It's not that they are trying to think what to say to us next. They're not aware of us. They are in the place where they're processing this information. And we feel awkward and we jump in. And doctors are particularly bad at this. They start giving all kinds of medical detail into the silence, when actually what is required at this point is silence. Now, the difficulty is that if you're in the room with the person, even if you're in full PPE, they can see that you are still attending to them, and we do that little shift in position, and maybe we can reach out a gloved hand to touch their shoulder or something like that. But once you're on the phone, what do you do so that they can continue to use the silence to work? And so we've been looking at kind of holding noises, if you like, where we're saying you take your time and then give them another pause. And, you know, I'm not in a hurry. This is important for you. You can express your compassion. I'm so sorry that we're doing this on the telephone, but don't hurry. It's a lot to think about. And then shut up again. And, you know, when you feel that the silence has been long enough because you're starting to feel awkward, that's probably about half the amount of silence that's actually required. So we have to get out of our own way and just keep quiet. And it's so hard, particularly on the phone. And what we've discovered during COVID is that actually video conversations are the least interfered with way that we can talk to each other. If we're person to person, we're in PPE and they can't see our facial expressions and we can't see theirs. If it's on the phone, there's nothing except the auditory cues. But actually, when we talk to each other the way we're talking now, you know, as I'm talking, I can see Maria smiling and nodding, and I'm thinking, phew, I'm not getting this too badly wrong then. And that's really important, isn't it? And also, when do you speak next? Because you speak across each other on the phone all the time. But we can see when somebody's getting ready to speak on a video call. So I would say exactly the same thing. It's about the silence. It's about naming your compassion because they can't see it. I am so very sorry. I wish I could be with you while we're having this conversation. Oh, if only we could be in the same room now while we're talking. It's making me feel sad to talk to you about this. I can't imagine how it must feel for you. We have to say it out loud because they can't read it in our faces. And I think the thing I would say is to trust yourself. If you're feeling that, that's the right thing to feel. So tell them that you're feeling that.
Fab, thank you very much, Kathryn. So we're now going to go to our audience questions. The first question I'd like to ask, which I think leads on beautifully from that, is from Alison. And Alison says, I'm always unsure if I should be very professional when comforting relatives or allow an element of sadness but not crying to be seen. So I think the question is it okay to cry around relatives when we're comforting them? And I think I'd like to go to Maria with this one, please. I think you're muted, Maria, sorry.
Sorry, yes, I was muted. I do love that question. I think that we show empathy in lots of different ways, and I think that there's a very big difference here, I think, between somebody having just a little sort of tear in the corner of your eye to being somebody that needs to be comforted by relatives. And I think that's the line for me. You know, I've been with an awful lot of people when they've died, and I have sat there literally holding somebody's hand over a bed, talking to somebody while they die, and it is the most beautiful experience to be in. What a most privileged place to be. But when you look at that person that is dying, and you look at that person that you are with, and they are talking to you about their families and their thoughts and their everything that they had planned for the future that is no longer there. And sometimes, and it happened to me quite a few times when something in here had a real connection with that person. I can't even begin to describe there's so many similarities that you see in that person, in that family, whether it might be their children are the same age, or you know, their dad looks a bit like you was, or they are the same age. I don't know what it is, but sometimes that connection is there. And I think you'd have to be a very, very hard person not to just, oh, okay, couple of tears rolling down your face. And for me, that is acceptable. That is empathy at its best. I think becoming somebody literally sort of sobbing is not necessarily acceptable. And I also have had to say to somebody before, you know, somebody has died, somebody's in the room and the families are there, and I've sort of said, okay, I'll just going to go and get whatever I need to get, and I will come back. Literally turned, because families are together. I've turned, I've gone out, I have wiped my eyes, and I've gone back in. So yeah, personally for me, it is acceptable in the right place, and you've got to choose your family and the person that it is with carefully. That's just my own experiences.
And I would agree with you, and certainly that describing of what to expect as somebody is dying is something that I have done in outpatient clinics. I've done it on ward visits. I've done it during a hospice ward round. And you know, I must have had that conversation hundreds and hundreds and hundreds of times. But every person I've had the conversation with, for them, it was the first time. And I've never got through it without my voice breaking or without dripping a tear, ever. And I think sometimes actually it would be more worrying if you didn't feel at least something of that sense of what is facing this person. And we've gone into caring professions because we're compassionate people who want to be caring. So yeah, if you're howling and you're using their tissues and they're having to mop you down, like Maria says, you've crossed the line there. Make an excuse, go to the loo, do something, escape. But to just be human in this really human situation, goodness me. I remember an article in the medical student BMJ when I was a very young student, and the mother of a child who had died of sepsis in hospital while she was not present. Child was neutropenic, doing well with leukemia treatment, and she'd been called home because the sibling had mumps and was crying for their mum. And during the several hours round trip, long before the days of mobile phones, the neutropenic child became suddenly sick and died. And the doctor who told her this news when she got back to the hospital wept and then apologised for weeping. And she wrote this wonderful personal view that said, goodness me, if you can't be with your child when your child dies, you want the person who was there to be someone who would weep. So we're bringing our personhood to our jobs, but that also brings with it risks. So as Maria is saying, self-care is really important. Supervision is really important. You always don't want to go to supervision when you feel at your most fragile and vulnerable, and that's when it's most important. And knowing who's got your back and who you can talk to is really, really vital.
Thank you so much both for your answers. My next question is from Terry. Do you think more needs to be done on death and dying for people with learning disabilities? And I'd like to go to Katherine first with this one, please.
I think this is a really, really important question. There is great evidence already, isn't there, that people with learning disability don't have equal access to care and treatment, and that people make assumptions about their levels of understanding and become overprotective about what's happening to people. And what's really frightening for every human being is not knowing what's going on. There is now a fantastic nurse professor of palliative care in learning disability, whose name is Irene Tufri-Wijne, And actually, she should have been running a conference about this very thing in Cardiff in September, and it's been cancelled because of COVID. But if you find her on Twitter, you'll be able to find the links to the webinar that is about this, which is about learning disability and the importance of enabling people to have information at a level that they can understand about themselves, about their friends who might be dying, about their families who might be dying. That there are some fantastic resources on Irina's website, and there's a wonderful series of books called Books Beyond Words that people who are training in learning disability will be well aware of, which includes a new book that's specifically about COVID. But there are books about dying, there are books about if you are dying, there are books about if a relative is dying, and there are books about bereavement. They are fantastic illustrations, and the person who knows the person best, the person with learning disability best, can help them to tell a story with names that are relevant to them through the book that explains things. It's vitally important that we don't depersonalise our citizens who have learning disability, and we find a way to talk to them and to explain things. Most hospital trusts now have a liaison nurse for learning disability in the trust. Just like you can send for a palliative care nurse when you don't know what to do next, you can send for a learning disability liaison nurse, and it's absolutely important that you do.
Thank you so much, Kathryn. My next question is from... Oh, George, sorry, Maria.
Sorry,
yes, of course you can.
Because I like Kathryn, I think that's an amazingly important question. And it in the University of South Wales, we've got somebody called Dr Stuart Todd, who runs the Last Days of Life research, and they have just done a huge sort of survey looking at living and dying with learning disabilities. So again, if you go onto Irene's Twitter, you'll find the Last Days of Life Twitter page, and lots of the publications that they have got out. But it is hugely important, and again, within Wales, we've been really lucky that there's a consultant learning disability nurse in West Wales. When we held, we took the departure lounge on the road, so we took this sort of talking about death and dying, we've taken it across some parts of Wales, and we've done something in Llandrindod Wells, and we did something in Carmarthen, all in local banks, so very sort of just pop in, say hello. But Paula, who's the consultant nurse there, is really, really keen that we do something very specifically for some learning disability patients, where we can adapt some of the communications we've got that will be for easy read for learning disability clients. So I think it's massively, massively important, and it's something that we really can't, and it's one of the reasons that we really need to think about the terminology we use, because, you know, if you've got somebody with an autistic, somebody who's autistic, they might take something very literally that we say. So when we start using terminology that is not correct, somebody will literally sort of be looking at what's passed over because that's what you've said. So I think it's so important that we look at and give credit to sort of doing something different for learning disabilities.
Thank you so much, Maria and Kathryn. My penultimate question is from Becky. It's how can we protect our mental health when working in palliative care or looking after dying patients as healthcare professionals? I'll go to Maria first. And your mic's on mute. Sorry, Maria. Again.
Sorry, again. I think maybe we've already touched on that to some extent. I think you need to, one of the things I learned very early on in my nursing career was that you needed to be self-aware. Resilience was something that I also learned very early on. And I think having those two things, you need to know when you need time and help. And as I said earlier, to some extent, it's very hard to help somebody else if you don't help yourself. And how can you, not even dying patients to some extent. How can you help somebody if you are not giving yourself the time and care that you need? Kathryn has already alluded to supervision, but I think one of the key things is you need to allow yourself time. You need to know what makes you unwind, because whether we like it or not, we do take things home, and whether we want to or not, some things will just sit with you for a day or two, because maybe it's really hard for you not to let them sit with you, but you can't let them sit with you and eat away at you either. So you have to be able to leave it sit with you and almost process it over a couple of days, and then give yourself time and care. And if clearing your mind is going for a run, do that. If it's sitting in a spa, do that. You sort of need to figure out what makes you tick and what you need to protect yourself to some extent. Caring for other people can ask a lot of us, and I think we need to be able to look after ourselves in order to care for others.
Thank you, Maria, and I'll go to Kathryn now.
So I simply endorse what Maria's saying. Find a way to not keep it in your head. And my way of not keeping it in my head was to write it out of my head. So I put a stack of A4 sheets, because I only one A4 sheet, because otherwise I felt I was being self-indulgent. But they are the papers that became the book with the end in mind, because they were the people who I was carrying around. And it's not a bad thing that we carry them around. It's just that it becomes too heavy, because we've got to take our best self into work each day. And there are lots of things that we carry around, and they're not all bad. So, in my writing it out, because it just is too distracting to keep carrying it, is the first baby that I ever delivered, for example. So everybody needs to find a way to put the things that somewhere that is safe and somewhere that you trust. And what I trusted was an A4 pad, but you might have better friends than me.
Thank you very much, Kathryn. My final question for you both for tonight is, I'll start with Kathryn, is, do you think we should be afraid of dying?
Oh, great question. I have to say, based on my sample of, I don't know, somewhere between 10 and 15,000 dying people, I've got less afraid, progressively less afraid for me and for the people that I love, the longer I've spent time looking after dying people. I think we might need to be afraid that in a generation's time, we mightn't have the same level of services available to us. And we're going to live to a greater age, and you're going to live to an even greater age, and there will be new problems ahead. I don't think dying is a problem, and I think perhaps living miserably might be more of a problem in the future.
Thank you very much. And Maria?
Unmute myself. Yeah, I totally agree with what Kathryn's just said. I'm not afraid of dying, and I'm not afraid of the process of dying. And I have to say, I have cared for people who have had lovely deaths. And I say it again, it's the most privileged place that you can possibly be, is there with that person at that time. It is equal to that bringing somebody's baby into the world kind of thing. I've always felt that. I'm not afraid of the process of dying. I am afraid of that time before that, when and it is that care issue. I am afraid of that, and I think being a nurse, we probably make the worst patients. So there's a little bit of me that is afraid of that, that growing old with lacking my quality that I feel is important, and for me is that lack of, or losing that control. Now that does scare me a little bit, but actually dying doesn't. So
thank you very much. Thank you, Maria, and thank you both so much for your answers. I'm absolutely gutted. It's been an hour already. I can't believe how quick it's gone. I've enjoyed it so much. I think you both have been amazing, and unfortunately we've not been able to ask all the questions. We've had so many submitted by the audience tonight, which is really, really good. I guess we'll have to do a part 2 maybe at some point, which would be really good. So thank you so much, Maria and Kathryn. Thank you so much as well to Molly Kilty, my co-host, who's been working really hard behind the scenes, sourcing and sending me in all the questions. Thank you to Rob and Gary, who's also been working hard behind the scenes, our AV team, who've made this possible and have been working tirelessly through all of our webinars this series. And thank you to the audience as well for tuning in and sending in your wonderful questions. So this webinar will be going up on YouTube, the RCN's YouTube channel, along with all our other ones. We won't have webinars next week. We're taking a break, but then hopefully after that, we're looking at putting another one on every week, then on every Thursday night. So thank you again so much for tuning in. I hope you have a wonderful weekend and stay safe out there. Thank you.